I really enjoy talking about prostacyclin therapy and managing these medications. And so I was really thrilled when Kim invited me to talk to a larger group of patients. This is a conversation I've been having with people for the last decade since I started working at the Pulmonary Hypertension Clinic in Vancouver. And you know, it's just such a great opportunity to present to more than one person. It's a little interesting because usually when I'm presenting this information, it's for a very targeted reason. So, you know, either someone is, you know, needing to start on the medications right away, or it's something that they're going to be looking to start coming up in the next couple of months. And so often I will, you know, gauge my presentation that way. I asked Kim, you know, if there were specific questions that people had, but I think the appetite is just for a broad base of information, which is what I'm going to present today. So if I don't cover something, if you have a specific question, make sure you do ask that question in the chat. And we will talk again. And as always, I'm open to people reaching out, give the clinic a call, send me an email, et cetera, and when I get a moment, I'm happy to return that phone call and answer questions as needed. So for those of you who don't know me, again, I'm Lisa Kolkman. I'm the nurse practitioner in the Pulmonary Hypertension Clinic, and I manage the prostacyclin program out here in Vancouver, BC. And so just a bit of a caveat, you know, some of you clearly are not from British Columbia and you're from across Canada. The medications are the same. In general, we practice the same across Canada, but there are going to be small specific nuances that differ between clinic to clinic across Canada when we're talking about these medications. And so your first resource and the people that you should trust are the people that you have a healthcare relationship with already in the province where you are. We actually meet the nurses, et cetera, you know, once a month currently, and run through common problems that we're all experiencing with these medications, or, you know, share our expertise and our tips and our tricks. So I know a lot of the ways that different nurses across Canada practice, and, you know, we all practice pretty much the same. So when I talk about these medications, I always like to talk about, you know, why it is that we're thinking about them, why it is that we're asking you to start them. So you guys, if you're here and you're thinking about starting on these medications or you're on these medications, you already know this information, but it's helpful to always kind of think about what these medications are doing, what's happening in your body, and why we're asking you to consider starting on one of these medications. So pulmonary hypertension just means high blood pressure in the lungs. You know, you can have high blood pressure in your body, which is very common. You have a second circulatory system that goes out to your lungs. And it's very rare to have high blood pressure in there. We have hundreds of thousands of people in the province of BC who have high blood pressure in their body, and less than 1,000 who have high blood pressure in their lungs. And this can happen out of nowhere. So I have quite a few patients who are young, 21, 30s, 40s, who have high blood pressure in the lungs, and they don't have any other medications, but it can also be associated with many other diseases. And it's really important for us at the beginning to understand why it is that you have pulmonary hypertension, because the treatments for each type of pulmonary hypertension and how they affect your body are different. And so that's why when you first get diagnosed with pulmonary hypertension, you have so many tests, because we need to make sure that we're choosing the right medication to choose, because we know that you have a specific type of pulmonary hypertension that this medication will help. So what happens is in pulmonary hypertension, instead of making normal blood vessels, so normal blood vessels are round, they're thin-walled, they get bigger, they get smaller, depending on how much blood or oxygen your body needs. In pulmonary hypertension, for whatever reason, the signaling systems in the blood vessels of the lungs go awry. And so the blood vessels in the lungs, they squeeze down. This causes there to be more muscle cells in the blood vessel walls. And those muscle cells hypertrophy, or they get bigger. And because the heart has to pump the same amount of blood through a tiny space, this increases the pressure in the lungs. And if you can imagine that increased pressure causes shear stress on the blood vessels of walls, which can make there be scarring, scar tissue, and blood clots that form on the inside of the blood vessels. And we don't tend to see difficulty in the tissue of the lungs. So the tissue of the lungs of patients who have pulmonary hypertension are usually pretty healthy. Again, this is a disease of the blood vessels of the lungs. And the other place that we tend to see the problem is on the right side of the heart. So the right side of the heart is the part of the heart that's responsible for pushing blood through the lungs. And so, you know, as it starts meeting that higher blood pressure in the lungs, as it starts having to pump against that higher blood pressure in the lungs, it's a muscle. So just like any other muscle that you have in your body, it's going to start to work harder. It's going to get bigger. It's going to pump stronger. It's going to try to adapt to deal with high blood pressure in the lungs. But over time, it's a little bit like running a marathon, 24 hours a day, 7 days a week for your poor heart muscle. Over time, it gets tired, it gets damaged, it starts getting stretched out. And that's when you often start experiencing the more severe symptoms of pulmonary hypertension. So it's important to remember that pulmonary hypertension is a progressive disease for which there's no cure, but there's a lot of treatments that are available to pulmonary hypertension. And so these are, you know, one of the best medications that we have to treat pulmonary hypertension, which is why often at some point in your journey with pulmonary hypertension, you'll come up against the question about whether or not you want to start on one of these medications and whether these medications are right for you. So I'm going to talk a little bit about why prostacyclin therapy. So prior to the 1990s, there really wasn't any treatments for pulmonary hypertension. Patients would develop pulmonary hypertension, and then typically within about 3 to 5 years from the diagnosis of pulmonary hypertension, they would pass away from the condition. Doctors and scientists knew about pulmonary hypertension probably from the 1950s. There was a pulmonologist in the United States who was studying pulmonary hypertension, but it remained a relatively rare disease that not much was being done about until the late 1960s, early 1970s, when women started taking amphetamine-based weight loss pills. And there was a huge outbreak of pulmonary hypertension. In Europe, US, and Canada for these women who were taking these weight loss pills. And so the World Health Organization got involved, just like the World Health Organization gets involved for tuberculosis, like they did for the Zika virus or for like the coronavirus. And they put a lot of structure and support, money, financial support into understanding the cause of the disease and what to do about it. So despite all that effort, from 1970 till 1990, they weren't able to create any medications to treat pulmonary hypertension. They knew that patients who had pulmonary hypertension were missing something called prostaglandin or prostacyclin. So they just weren't making enough of it. And so what they tried to do was synthesize prostaglandin in a lab, which they were able to do, and then distill it down into a pill form where you could take a pill and swallow it, and it would go out into the lungs, and it would dilate out the blood vessels of the lungs and return them to a more normal state. Unfortunately, all the way from 1970s to the 1990s, they were unsuccessful in their attempts for those medications. They did, however, know that if they could give prostaglandin or prostacyclin through an intravenous, it would end up in the lungs and it would treat the blood vessels of the lungs. And so what they did is the very first trial of these medications in pulmonary hypertension occurred in the early 1990s. There was a lot of, at that time, patients who had pulmonary hypertension, if they were in the hospital, once the disease got advanced, so they were developing heart failure, they were retaining fluid, they were more short of breath, they were requiring oxygen and very close monitoring. Really at that time, the only treatment was for lung transplant. And so people would be in the hospital waiting for the lung transplant. And as you may know, lung transplants are not unlimited. They're not just available. They're not just waiting. There's a lot that needs to happen in order for someone to have a lung transplant. And even today, if somebody gets evaluated for a lung transplant and accepted for it, sometimes it can be 1 year, sometimes it can be 2 years, sometimes it can be longer before a lung transplant will become available. And so since I had all of these people in the hospital waiting to be treated for, or waiting for a lung transplant, they thought, why don't we run a trial of using this medication through an intravenous in a monitored environment and see how it goes? Interestingly enough, it went very well. So they put these patients on this medication, so on the IV Baprostenol, it was called Flolan at the time, and patients improved. Some of them improved so much that their heart function, so their blood pressure in their lungs went down, their heart function returned, they got out of heart failure, they weren't on oxygen anymore, and they didn't really either need a transplant or need to stay in the hospital. And so now you have, this is a disease of a young woman, potentially a mother with a family in a hospital on an IV medication. And as long as she stayed on the IV medication, the pulmonary hypertension stayed controlled. If they tried to reduce or withdraw the IV medication, the pulmonary hypertension would come back. And so they eventually had to invent or design a way to take prostacyclin therapy at home. And that is where we are today. Interestingly enough, there are, we've had major developments in the field of pulmonary hypertension since then, since the 1990s, but these are actually still the strongest and most effective medications that we have to treat pulmonary hypertension. So there are lots of different oral medications, including oral medications in the prostacyclin pathway available here in Canada, and I imagine that many of you are on them. But despite that, these medications are still better medications. So we know this for two reasons. One is looking at the research evidence. So the research studies suggest that these medications are much stronger than the oral medications. The others is personal experience. So we have a lot of patients who are initially diagnosed with pulmonary hypertension when it's quite mild. Often they'll start on one medication, 2 oral medications, potentially even 3 oral medications now. But as we know, pulmonary hypertension is a progressive disease, and eventually those oral medications will stop controlling the disease. And at some point, they need to think about starting on the IV medication. And we know that when we start patients on this IV medication, they almost always improve. Okay, so there's both research evidence to suggest that these medications are stronger than the oral medications, and then there's our own personal experience. So there are a bunch of different ways to get prostacyclin therapy. The most common ways that we give prostacyclin therapy here in Canada are through an intravenous or through a subcutaneous infusion. And again, these are big words that I'm using, but I'm going to go into them in a little bit more detail in a minute. But you can see my nice man here. There's an inhaled version of this medications that's not currently available in Canada. They are looking at it, bringing it to Canada specifically for treating people who have lung disease, so damage to the tissue of the lungs. It is a medication that's available in the United States that we don't have here currently. But to be quite honest with you, I'm not sure we've particularly missed it here in Canada. I do think that there's going to be a role for this medication in lung disease, but I think for our general pulmonary hypertension population, we may have some better choices. The second is a pill, so that's Selexipag or Uptravi, and a lot of you guys at some point will come across this medication. It's an oral prostacyclin medication that you can take in the morning, at night. There's also an oral version of Remodulin that's not available currently in Canada, but Selexipag is a great medication, and we have many patients in our pulmonary hypertension clinic on it. Interestingly, the side effects are very similar, and potentially some are more bothersome to patients than other patients who are on the IV or the sub-Q, and some are less. So clearly we have differences in our receptors in the body and how we take medication into our body, but it is a great medication for pulmonary hypertension. But most of my talk today is going to focus on the other medications. So the IV medications, so through an intravenous, that's Caripul or Flolan, or through the skin, the subcutaneous medication, so that's Remodulin. I'm sorry, I'm also going to be talking about IV Remodulin as well. This is an implantable pump, and I'm going to talk about it briefly when we talk about the future of prostacyclin therapy through the end. But there are, again, this is what we currently have available in Canada, and I think it's important for you to make your decisions based on what exists as opposed to what potentially might be coming up. But that is something that is in the background and has been in the background and is occasionally used in Europe as well. And it has some advantages and some disadvantages from other medications. So when do we ask you to consider pulmonary prostacyclin therapy? There's kind of two different times in a patient's journey with pulmonary hypertension that they bump up this question about starting on one of these IV medications. The first kind of patient that has to deal with this question is somebody who presents with very advanced pulmonary hypertension. So probably 3 or 4 times a year, I'll meet a patient in an emergency department who is very short of breath, barely able to walk, potentially passing out with very severe pulmonary hypertension. And either because they themselves didn't recognize how sick they were, or the healthcare system wasn't able to identify pulmonary hypertension as the cause of their disease, they end up presenting very late in the disease course. And at that point, your risk of dying from pulmonary hypertension is very high. And so often we will come straight out of the gate, starting with all of the medications that we use to treat pulmonary hypertension. And especially we ask them to consider the strongest medications that we have, the best medications that we have to treat pulmonary hypertension, which is IV propranolol. So, potentially, they may start on the IV therapy and they may respond extremely well. And at some point, may be able to consider coming off of it for a couple of years. But some people start on the IV therapies right at the time of the diagnosis, and they stay on those medications for the rest of their life or until the disease progresses and they need to consider lung transplant. The second type of patient that we have that has to think about pulmonary hypertension is somebody who may be presented with a milder form of pulmonary hypertension. So a little bit of shortness of breath on exertion, but maybe they don't really have to worry about heart failure. So they're not retaining fluid, they're not on oxygen, et cetera, et cetera. The pressure in their lungs is high, but they're not in extremis. And so often those people can be on oral medications. You can be on oral medications for 1 year, 2 years, 5 years, 10 years, 15 years before you ever have to face this question with pulmonary hypertension. But it is pretty inevitable at some point you have to decide whether these medications are right for you. And what I have here on the screen is something called a risk assessment. And so this was developed by the European Respiratory Society and the European Society of Cardiologists. And what they did was they looked at registries of patients who had pulmonary hypertension. And what they looked at were different features of their pulmonary hypertension and different signs and symptoms and things they could measure about how someone was doing with their pulmonary hypertension. And then just saw how likely it was, this is science and researchers, that somebody would die if they had this feature associated with their pulmonary hypertension. It's kind of a morbid way to think about things, but you can kind of understand why it is that they did. So some of these things are clinical signs. So there's things that you can tell me about how you're doing with your pulmonary hypertension. And some of them are more objective measurements. So things like echocardiogram results, blood work results, your BNP tests, and then again, your heart catheterization comes in there. And so often what I do when somebody asks me to assess a patient and see if they're appropriate for pulmonary hypertension is I will pull out this chart and we will go through and we'll look. Do you have clinical signs of heart failure? So are you retaining fluid? Do you need to be on Lasix? If it's no, so you get a tick mark in the green column. If it's yes, you get a tick mark in the red column. How fast are your symptoms progressing? Are they progressing slowly? Are they progressing rapidly? Or are you pretty stable? Have you passed out? Are you passing out occasionally? So maybe once every couple of months? Or is this something that's happening fairly regularly? How well are you doing in your personal life? Are you still able to work? Are you still able to walk? Do you carry your own groceries? Do you mow your own lawn? Do you clean your own house? Or are you requiring help with that? Is washing difficult for you? Is bathing difficult for you? Is getting to the bathroom difficult for you? If you are, mostly managing, you're mostly independent with your tasks, you're going to get a tick mark in the green column. If you require tasks that require assistance with, heavier tasks such as mowing the lawn and cleaning your house, typically you're going to end up with a tick in the yellow column. And then if you are extremely short of breath, even sometimes when you're at rest, you're going to end up with a tick in the red column. We look at your 6-minute walk distance. How far can you walk? I know that's like the bane of most of my pulmonary hypertension patients' existence, but there is very good evidence that tells us that how well you're functioning is more important actually than the pressures that we measure on a heart catheterization. So, that 6-minute test is a very valuable piece of information for us, and, as unpleasant as it is for some of you. And so depending on how far you walk, again, you get a tick in each one of the different columns. We look at your BNP, which is an enzyme that leaks from the heart when it's under stress. And depending on those results, again, you end up with a tick in a green, yellow, or red column. We're going to look at an echocardiogram, and we're going to look at the pressure in your lungs. And there's specific numbers on your heart catheterization that really tell us how your heart is dealing with the pulmonary hypertension. So you can have very high blood pressure in the lungs, really high blood pressure in the lungs, and still be able to walk, hike, albeit at a slower pace than your peers, because some people are able to function with higher pressures just because of the genetics of their heart structure. And so all of those kind of decisions, we put all of that information together and then think about, is it time to start thinking about prostacyclin therapy? So if most of your tick marks are in the green column with 1 or 2 in the yellow column, we'll probably say, this is probably not a conversation we need to have today, but you just need to be aware of these medications and think about them in the future. If most of your tick marks in the yellow column, chances are we're thinking in the next couple of months, you need to start thinking about prostacyclin therapy. And then again, if you've got tick marks in the red column, slightly more urgent. Again, some people don't need to start right away on the prostacyclin therapy, even if they have a couple of tick marks in the red column. But once you start crossing over there, absolutely 100%, you should have a very, very thoughtful conversation with the person who you trust the most in the pulmonary hypertension clinic about whether or not it's time for you to consider prostacyclin therapy. So I'm going to be talking about the 3 medications that we use in the pulmonary hypertension clinics across Canada. And I'm going to talk a little bit about each one. It would be really nice if there was a medication that you could take that had no complications, that had no side effects, that you took once a day and you could take it and it would treat your pulmonary hypertension and you'd forget about it. But that's just not the reality currently. People are always looking at new treatments and new ways to treat pulmonary hypertension. I really love all of the medications that we use to treat pulmonary hypertension because I've seen how these medications can change people's life. I also acknowledge the downsides of being on these medications and believe you and understand when you're having a crappy day with side effects or you have a complication that derails your life and you end up in the hospital because of a complication, one of these medications. And so, I guess what I'm trying to say is there's good things about each one of these medications and there's problems with each one of these medications. And what you need to think about is which one of these medications is right for you. So the first one I'm going to talk to you about is the medication that we've used for pulmonary hypertension the longest, which is IV Caripul or Flolan. So for some of you who've been in the pulmonary hypertension world for a while, either you're on this medication or you were on this medication or you know of people who are on this medication. And so, this seems like a reasonable thing. For me, the conversations that I have that are the most difficult are the people who are just newly getting diagnosed with pulmonary hypertension, and we're asking them to consider this. When you frame it within the context of the disease itself, definitely, you can understand why you want someone to start on this medication, but this is clearly can be an very, very overwhelming thing to take on. Despite that, I've been doing this for 10 years, and I've seen people do amazing things with their lives on this medication and live amazing lives. And this is not, some kind of like Cinderella story. This is very real people, doing very real things. And I have been very impressed with some of my patients who are on these medications. Okay. So IV epoprostenol, which is either Caripul or Flolan. The vast majority of patients in Canada right now who are on epoprostenol are on Caripul. Flolan was an older version of this medication that required ice packs. And so when a version came out where you didn't require ice packs 24 hours a day on your cassette, the vast majority of clinics switched over it. There still are a few patients on the Flolan now that they also have one that's stable at room temperature. Okay. So the reason why Caripul is given through an IV catheter, again, is because it goes directly into the bloodstream, which then goes out into the lungs to directly get the medication right to the lungs, right where it's needed. Okay. It doesn't have to go into the stomach and then be absorbed and then go into the bloodstream. It's just directly into the area that it's needed. So epoprostenol goes out into the bloodstream in the lungs. It dilates out the blood vessels of the lungs, which helps bring the pressure down in the lungs, which takes the stress off the heart. People who are taking Caripul are going to notice almost immediately within a couple of days of starting on the medication that they feel less short of breath, that they're able to do a little bit more every day, and are going to start feeling better. So the medication, one of the most important things to know about this medication is that because it's a natural substance that we're just replacing in your body, it's just basically going into your body's using it, and then it's gone from your system. So it only lasts in your body for about 5 to 6 minutes before it's all used up. And so that is why the medication is given through a pump that runs 24 hours a day, 7 days a week. Basically, we are replacing what somebody who doesn't have pulmonary hypertension already has in their body. So we are just pushing the medication in there, your body's using it, and it's gone. Pushing the medication in there, the body using it, and it's gone. Okay. So the medication is administered through something called a Hickman line. I have 2 different pictures up here of patients of mine who are kind enough to share their beautiful pictures of themselves with their Hickman line. The one on the left is about a week old, and then the one on the right is several months down the road. So this is what a Hickman line is. We currently are using the purple lines, the one in the middle there, but for a long time we were using this Hickman line. The problem is you can see it's very soft silicone, and so some of my more adventurous patients were having problems with developing holes in their lines after a period of time. These are mostly designed to be in for a year or 2. If you start on prostacyclin therapy, you may be on this medication 3 years, 5 years, 10 years or more. And we don't often change the lines unless there's a problem with them. Okay, so getting the IV line put in. How I like to describe it is it's a procedure fairly similar to your heart catheterization. So for those of you who are able to tolerate your heart catheterization without problems, you're probably going to make it through this procedure okay. If you're somebody who hated your heart catheterization, probably I'm going to talk to the interventional radiology department and be like, hey, this person really struggled with their heart catheterization. They may need a little bit more support around some medications for feeling, sleepy, and some medications to help with pain. Okay. So procedure of putting this line in takes about 45 minutes. It's done here at VGH, just down the hallway from the cath lab. And it's done by wonderful physicians who are very experienced with working with our patients. Okay, so you go into the interventional radiology department in the morning. You talk to the radiologist or the fellow that's going to be putting the line in the day. That day, they're going to talk to you about the risks and the benefits of having that procedure, what potentially could go wrong, and then kind of how that procedure is going to go down. Once it's your time to have the procedure done, they'll bring you into a room, they'll move you onto a bed, and they will put a little IV in your arm so that they can give you some medication so that you feel less anxious and you feel less pain. They don't put you under, so it's not like you're unconscious and you're out. They just make it so that you're less aware of your surroundings. Pretty good idea when somebody's putting a line in. Then they give you local freezing. So they give you a little bit of freezing. They give you freezing up here on your chest, and then again, a little bit farther down. Because what they're going to be doing is they're going to be making a little tunnel. So they make a little cut down here, a little cut up here, and they make a little tunnel underneath the skin that goes over the collarbone into one of the blood veins that's just hiding right behind your heart there. And so you can see this line is, fairly long, but about, of course, I wore the wrong color shirt today. You can enjoy my white on white experience here. So about this much of the line, anywhere from about 4 to 5 inches of the line is going to be outside of your body. And the rest of it is going to be inside the body. If you were to poll the patients that I've had over the years who've had this line, 99% of them are going to tell you that the procedure was way easier than they thought it was going to be. They were all very stressed out about the procedure. They go have the procedure and they're like, oh, that wasn't so bad. And then there's always 1%, and again, through no fault of their own, where something doesn't go smoothly, or they have a bad experience on that day, or they, for whatever reason, the freezing or the medications don't work as well as they should. And they will tell me that it was literally the worst experience of their life and they will never do that again. So hopefully you follow into the 99%, chances are pretty good, but just be aware that there are people who do have problems and complications with the procedure. Okay, your line is in. So now you've got your line, so you're ready to start on the medication. This is the pump that we use for Flolan and Caripul. It's called a CAD pump, okay? As you can see, it's probably about 4 inches by about 3 inches and about 1 inch wide. It has 4 AA batteries in it, so it's probably not the lightest thing out there, but it's also not super heavy, okay? So this pump basically slowly pushes medication into you. Like I said, a little bit of Caripul, a little bit of Flolan, 24 hours a day, 7 days a week. So part of being on this medication is learning how to look after the line that you just had put in, how to program the pump, and how to mix up the medication that you have here, okay? Pump's pretty easy to use. Most of us use cell phones. If you can use a cell phone, you can use the pump. There's an on-off button on the side. There's an up-down button for changing the settings. There's a start-stop button on there. Again, you have your pump here. And then again, you have a long tubing. That's so that you can have some distance from your pump. So if you're going to the bathroom or you're going to the shower, you can put it on a shelf so that you can do that. And so then again, gives you a little bit of freedom. This is the cassette. So this is the medication. This is where the medication goes. So the medication goes into the cassette. It's a little reservoir that holds the medication, and it slowly over the course of 24 hours will empty as the medication leaves the cassette and goes into your body. I think mixing the cassette is probably one of the more difficult tasks that you have to learn with managing this medication, but I can tell you that I have taught people of all different types of educational levels and experience, and typically within a week or two, and about mixing 5 cassettes, people pretty much have the process memorized. It is important to know that not everyone across Canada has to mix their cassettes. So there are a few provinces where the medication is provided to you pre-mixed. We don't have that available in BC currently. It's exceedingly expensive, about $800 a week to provide cassettes mixed. But we do offer a respite service. So if for some reason you're having a surgery, or maybe your life is upended because somebody in your family has passed away, or things are really stressful, you're going to school, you have an exam, and you just need one thing taken off your plate, it's pretty hard to have a chronic disease. If we can take that one thing off your plate for you for a couple of months, I can apply for coverage to have your medications mixed for you for a period of time. Okay. So mixing a cassette involves syringes and needles. So drawing up a liquid, diluting a powder, and then putting it into the cassette. That needs to be done, typically people, when they're first starting out, it takes about half an hour to mix up a cassette. As they get more experienced, some of my young patients who've been on the medication for a while tell me that they can get a cassette mixed within 6 to 8 minutes from start to finish. So if you think about it, if you're using one cassette a day, 7 days a week, anywhere from 10 to 30 minutes, you're looking at about 4 to 5 hours of your life every week that's going to be involved with caring for the different aspects of this pump. So what this looks like in the end, again, I apologize for wearing the wrong color, is most people, I would say, again, 99%, they have all of this underneath their clothing. So, in the morning, they'll put their shirt over top, and then they will wrap their little cord up, and they will put it in a pouch around their waist, or they'll put it in a bag across their chest. In the beginning, when you're in the hospital, we recommend you use the pump bags that are provided by the company. But as many of you know, over the years, people get very creative. And I had one patient specifically who probably had a different pump bag for every color of outfit that she matches. So, a question that people often ask me is, are people going to know about this? Are they going to see that pump? I think people that you are intimately involved with, so your friends and your family, are going to notice. I think it's inevitable as they see you. The pump doesn't make a ton of noise. You can keep most of this stuff underneath your clothes. But in general, in average, if you're out in public, I don't think that the average person would notice that you're on the IV medication. Okay, so that's IV Caripul. And just let me quickly check my time. I'm about 20 minutes through, so we're going to move on and we're going to talk about Remodulin or the other medications that we use for pulmonary hypertension. So this is sub-Q Remodulin. So sub-Q Remodulin, the story of this is really interesting. So there was a business person in the United States whose daughter developed pulmonary hypertension, and when she learned that her daughter was going to have to start on IV propranolol, she started a pharmaceutical company and tried to develop a better way to administer Caripul or Flolan, and tried to come up with different types of medication to treat pulmonary hypertension. So this is literally a medication that was designed by someone who has a family member who has pulmonary hypertension. And what they did was they took the molecule that we use, or a similar molecule to the one that we use for Flolan or Caripul, and altered it in a way so that you could take it in different ways. Again, there's an oral version, a pill version of this medication. There's an inhaled version of this medication. There's a subcutaneous version, which is the one that we're looking at here. And then there's an IV version of this medication. So the positive things about Remodulin is that it's a lot smaller and it's a little bit simpler. Well, I won't say that. I'll say it's a lot simpler to manage. So you think about the IV and the pumps, et cetera, and all of that stuff that we were looking at today. This is the size difference in the pumps. So you can see there's quite a significant in the size and the weight of the pump. And instead of needing to go into the hospital and getting an IV put in, this is administered through a subcutaneous injection port. So this is an example of one of the products that we use. So this is something that's often used for people who have diabetes. So I have a young friend who's less than 10 who's on an insulin infusion who uses the Clio. It's used for pain management. So sometimes cancer patients who have a lot of pain will get their pain medications through here. So this is used for other things as well besides pulmonary hypertension. So this subcutaneous injection site can really go in various parts of your body. So back of the arms, in the stomach. They say you can use your love handles and your legs. I would say 95% of my patients use either the backs of their arms or their stomachs. The stomach is a good place because if you want independence and you want to look after all aspects, working here is relatively easy to do. Back of the arm can sometimes be less painful for people, but not everyone. Some people have problems with more discomfort in their stomach. And so for some people, dexterity of trying to access a site in their back of the arms is a little bit more difficult. You can kind of eliminate that issue with the medication if you have somebody involved who can assist you with some of these tasks. So with the Remodulin, so like I said, the first thing is this subcutaneous site. So pretty simple to put in. It's something that you would be trained to do. I'm going to show you on my happy little red blood cell. But basically, the site comes preloaded in a little cassette like this. The cap comes off. And basically, on your arm or on your stomach, you're going to support your skin. And after doing some cleaning and et cetera, there's clearly more steps than that. You're going to inject the site. And then you're going to see my little site is there. So relatively simple tasks-wise to put one of these in. Once the site is in, it's usually good for 1 month, 2 months, 3 months. I have one lady out in the interior who is able to go to like 6 months, 9 months with one site. But most of my patients are looking at, once the site is in, they can use it for 1 or 2 months. So Remodulin comes pre-mixed, so it's a liquid already. And so you're just going to use a teeny tiny syringe. You see the little tiny syringe on my tray here. They're going to draw the medication out of the vial, and you're going to load it into this little pump here. Again, there's the tubing, the extension tubing, so you can get away from your tube, from your site, and have a little bit of flexibility. And basically, once every 3 days, you need to fill up that syringe. So this entire piece gets replaced every 3 days. So you draw up your medication into the syringe, you load it into your pump, and then you prime the medication out through your tubing. You take the old one off, that's empty, and you put the new one on. In general, it takes people about a half an hour to work through this process of washing their hands, getting the tray ready, setting up their supplies, programming the pump, et cetera, et cetera. But again, this is something that you're only going to have to do every 3 days, as opposed to Caripul or Flolan, which you're going to be doing every day. So looking at the two medications side by side, it really makes you wonder why 100% of the people aren't on this, which is lighter, smaller, simpler, than this, which is heavier and slightly more complications. There's two kind of main reasons why people aren't all on Remodulin. So the first one in BC is specifically is cost. So Remodulin is 2 to 3 times more expensive than Caripul. And so the government makes me think up of a very good supported reason why someone needs to be on Remodulin versus Caripul. Generally, if I think it's in the patient's best interest to be on Remodulin instead of Caripul, 100% of the time, the government has agreed to cover that medication for me. But again, it needs to be a reason that makes sense. And we're going to talk about those reasons in a minute coming up. The other reason is site pain. So for those of you guys who've met patients on Remodulin, people really have a varied response to site pain. When I think about the patients that I've had over the years, either people do extremely well with Remodulin, or they do kind of well with Remodulin, or they do completely horrible with Remodulin, okay? So I would say the vast majority of patients have fallen to the I've done really well, to the, I'm doing great with Remodulin. And then I say a very small portion of my patients are the ones who have done horrible. But the ones who have done horrible have really struggled with pain. So when I'm talking about pain, I'm talking about pain at the site of injection. So where the site is. It's not putting the site in itself that causes the pain, the medication itself is irritating to the skin, and the skin can become very red and inflamed, and the nerves around the site can also become red and inflamed and irritated. And that nerve pain can be really, really disruptive to some people. The good news is if you're somebody who really struggles with that site pain, typically most people are only experiencing that severe pain from day 3 to about day 7 or 8, where their site is in. And so if you are somebody who can make your sites go longer, so every 2 to 3 months, having to deal with 5 to 7 days of pain may be a meaningful trade-off for the quality of life that you get on this medication if you have a long break in between. The people that I've seen struggle the most are the ones who have very severe pain or are frequently having to change their sites. So, I mean, I have many patients who've been on this medication for a long period of time, who've done extremely well with this medications. And I have patients who tell me that they have no pain at all with this. Unfortunately, we're not going to know, beforehand whether you're going to be somebody who's going to do extremely well with this or you're going to do poorly with this. And in a section coming up, I'm going to talk about strategies that I've learned that have worked for some of my patients over the years. The last medication I'm going to talk about real quick is called IV Remodulin. So again, it's the subcutaneous Remodulin in an IV form. So the benefit of IV Remodulin is, we talked about Caripul and how the medication only lasts in the system for 5 to 6 minutes. The benefit with Remodulin is that it sticks around in the body for a lot longer. So we're talking on the orders of 30 minutes to 4 hours, varying depending on your ability to manage. So if an emergency crops up, you have a little bit more time to fix the problem. If it's Caripul, drop everything and run. If a problem crops up, with Remodulin, that's IV or sub-Q, you have a little bit more time. You don't need to be, well, it's still an emergency and we suggest that you get on it right away. It's not, you have a little bit more free time, which makes it a little bit of safer medication to use. I've had less patients on IV Remodulin than I have had on Flolan, Caripul, or sub-Q, but there are very specific patients who I find it very useful for. So I have a lady who was on subcutaneous Remodulin who had problems with site pain, but she was deaf. And so she didn't think that she would be able to communicate with emergency personnel if she was on Caripul or Flolan. Whereas with IV Remodulin, she could call her daughter who could communicate with emergency personnel for her and help her through the process of getting the medication up and running again. And we're going to talk about what the emergencies are that can happen with these medications and why it's so important. I've also used this for people that maybe don't do the best job of answering the phones when I call them or reporting issues to me because they have other things going on in their lives that are very stressful. And so sometimes it can be safer to be on this medication than on the IV medication. So looking at these side by side, hold on. Looking at these side by side, just to move my Zoom screen over, my apologies. When you are looking at the differences of these medications that we've covered, there are some mild but key differences between them. So the question of efficacy, so how effective are these medications? Are they the same in terms of efficacy? The physicians that you work with will almost universally tell you that both of these medications are exceptionally good medications. They still remain the best medications that are available to treat pulmonary hypertension. Potentially, IV propranolol has a theoretical advantage, and if you were to ask the physicians that you work with which ones they would end up on, I think most of them would choose IV propranolol, but maybe not 100% of them. So I've used all 3 of these medications. I'm very happy with all 3 of these medications. I don't know if we were to do a head-to-head trial, whether one of these medications would come up on top. Unfortunately, that's not a trial that's ever going to happen, and the information that we have is based on how the research studies were designed, how people responded in those research studies, and and large registry data looking at these medications. Will you need a hospital stay? So for IV epoprostenol and IV Remodulin, almost 100% of the time, you're going to need to have a hospital stay. I have heard of 1 or 2 starts happening recently in some of the other provinces at home, either because the patient had such a strong aversion to going into the hospital, or there's been an issue with healthcare resources and beds. And so I wouldn't say this is something that's going to be offered frequently. I think the amount of resources that it would take in order to make this something that was safe for the average population is probably beyond the ability of what we have currently to do so. I would prefer my patients to be in hospital, but there is the option there. Sub-Q Remodulin, on the other hand, is completely different about 100% of the time now, unless somebody has a learning need that I need to support. Those patients are starting at home, and I think that's a perfectly acceptable option. Cartridge change, again, epoprostenol, you're looking at every 1 to 2 days. You're needing to change the cartridge. Remodulin through the sub-Q every 3 days, and IV Remodulin is every 2 days. So epoprostenol is probably the most labor intensive, followed by IV Remodulin, followed by sub-Q Remodulin. You need a backup cassette. So patients who are on Caripul, they have to travel with an emergency kit. Everybody has to travel with an emergency kit, but patients who are on Caripul need to travel with a pre-mixed backup cassette that they wrap in ice packs that they bring along with them in case they run into an emergency from far from home. Is it pre-mixed? So IV epoprostenol, the answer is no. Sub-Q Remodulin, yes, the medication comes pre-mixed, and IV Remodulin, no, you do need to mix up your cassette. We talked about half-life quite a bit already. Again, Sub-Q Remodulin and IV Remodulin have the longer half-lives and are a little bit safer of medications. Pump size, so IV epoprostenol has the heaviest pump, followed by IV Remodulin, and then by Sub-Q Remodulin. And then major problems. I talked briefly about emergencies, and I'm going to talk about emergencies a little bit more. I can see that I'm quickly running out of time here, though, so I may not be able to get into them in the detail that I'd like to. But the major issues are for the IV medications. You can probably run into them with infection and problems. Sorry, you can have 2 different types of infections with IV epoprostenol. So you can run into problems with bloodstream infections, or you can run into problems with infections at the site. So we are bypassing the natural protective immune system that we have, which is our skin. The skin prevents bacteria from getting into the body. And we're making a little hole in it, whether it's the sub-Q sites or whether it's the IV sites. And so people sometimes get infections around the sites where these come out. Those are typically treated with antibiotics orally and typically tend to be self-limiting, only being bothersome for a couple of days. But there can be more serious infections. You can get bacteria in your bloodstream, and you may need to come into the hospital to have your line changed. The other issue is this question of rebound pulmonary hypertension. So if for some reason you stop your medication suddenly, all at once, all of the pulmonary hypertension you have will come back quickly and put a lot of stress and strain on your heart. So part of starting on this medication is learning how to deal with those emergencies, what are the different emergencies that can crop up, and how we can support you through those emergencies. And so I think IV epoprostenol probably is one of these medications you need to pay a little bit more close attention to that, again, just because of the short half-life, but it is also a problem for the other 2 medications as well. So these medications should not be stopped suddenly. Something to think about, if you want to choose one medication, it doesn't mean that you need to stay on it for the rest of your life. So you can switch back and forth in between these different medications. It's not easy, it does take time. Typically a transition between the 2 medications will take a couple of visits for teaching. Typically it will take anywhere from 1 week to 1 month to transfer in between these new medications. So it's not something that you should undertake lightly. immediately. But if you're really hating your prostacyclin therapy and you think you'd do better on another one, absolutely 100% broach that topic with the rest of your team.
So we had talked briefly about the fact that being on some of these medications, it's important for you to be close to not necessarily your pulmonary hypertension clinic or your pulmonary hypertension provider, but close to an institution where you can receive the emergency care that you need in case of something untoward happening, like your line falling out or your line getting blocked. We talked a little bit about how sometimes we have to manage, look at your physical capabilities. So, how strong are your hands? Are you capable of doing up zippers, doing up buttons, opening up jars, etc.? Because some of these tasks require either fine motor or gross motor skills, and so we like to assess that. Vision. So as we get older, we all start losing some of our ability to see things up close. And so it's important for you to see an optometrist beforehand to make sure your vision is doing okay. Again, and sometimes it's worthwhile going to prescription lenses if the drugstore glasses aren't necessarily working out for you. Hearing. So how well can you hear? Is there anything we can do to optimize your hearing, not only for the learning aspects of things, but also for the emergency management? Cognition, again, if somebody's getting a little bit older, how are we doing with our thinking and our critical thinking skills, our emergency thinking skills? Are we starting to struggle with our short-term memory? Are we able to do our banking? Are we able to live independently? Are we able to make our appointments and take our medications? Are you going to be capable of managing one of these infusions in a safe way? Learning. So all of us learn in different ways. I personally do well if somebody is speaking to me and I can take notes. If I can't take notes, I can't remember a thing that is taught to me. So it's just the way that my brain was taught to learn, and probably some intrinsic skills that I have with my way of learning that I need to take information in and write it down in order for it to stick. Other people to do better with stuff presented in different ways. So they like to read, or they want to watch a video, or they like to have a handout so that they can go back and look at things. And so some of the assessment for learning is, will you have the capacity to learn all of these complex tasks, but also which is the best way that we can get you the information that you need. So mental health, I mean, this is a stressful time for everyone. Having a significant health condition can cause you both emotional and psychological distress, can cause financial issues, all of that kind of stuff. So really just checking in to see how you're doing. Again, none of this prevents you from starting on these therapies. It's just information that we need to take in to decide which is the best one for you. So I've had patients who have struggled with anxiety, struggled with other mental health issues, who have needed to, check to make sure that they had the appropriate emotional support and resources to help manage them through this process so that they're able to start. Some people who have psychiatric disorders that we're not capable of managing, so they need to go to the hospital to be admitted, or they lack the capacity or the insight to be able to manage these therapies. Sometimes in those cases, we stick with oral medications. And part of those questions we ask just to make sure that you're safe on these medications. Social support. So this is a topic that comes up quite regularly. As we get as a Western society, we tend to be relatively independent, meaning often people already understand how much having an illness has impacted their relationships around them. So some people are good at asking for help and support, and other people struggle with asking for help and support. In some clinics, there's a requirement that you have a backup person or a support person with you to kind of learn about the medication, or at the minimum, be around sometimes to help you out with mixing or communicating with other healthcare providers in case of an emergency. For me, again, this one isn't a hard line. It's not like if you don't have a support person, I'm not going to let you start on prostacyclin therapy, or I'm going to tell you that I think this is a bad idea. Some of it is just a little bit understanding the risks around starting the medications without support versus the risks of not starting on the medication at all, and then trying to come to a balance that makes sense for your particular situation. Contraindications to central line. This has come up twice now in our prior presentations. So there are some times when people don't do well with a central line. So sometimes if people have had a heart attack and they need to have stents put in, so they have an angiogram, a cardiac angiogram, often you can't stop the blood thinners for a period of time. And so maybe it's not a good time to put in a line to receive some of these medications. And then again, in some clinics, having a hole in the heart or an atrial septal defect is reason to not put in a central line. Usually this is in the congenital heart disease population, so you were born with a hole in the heart, as opposed to other types of holes in the heart that may develop if you have pulmonary hypertension. And for those of you who this seems a little bit confusing, overwhelming, if you watch some of the prior sessions, there's a little bit more information available there. So dosing. So everybody has a different number of receptors for these medications in the body. So often what happens when we start on these medications is we start on a small dose and slowly work our way up. Okay, these are very strong, very concentrated medications, and we need to start them in a safe and monitored manner. So you may have a friend who's on Caripul, and you'll notice they mix the medications a different way than you. Maybe they put 1 vial in, maybe they put 2 vials in, maybe they put 3 vials in. I've had up to 8 vials of Caripul in each one of the cassettes. And then again, they also run at different rates. So when you program the pump, maybe you put a different number in than somebody else. And again, some of this is because these medications are weight-based. So if you weigh more, you need more medication. If you weigh less, you need less medication. And again, we all have an intrinsic number of receptors in our body that we need to fill up for the medication to work. Typically, it takes about 1 to 2 months to get up to the full dose of medication that you're going to be on. And often, even then, sometimes you'll come back to the pulmonary hypertension clinic in 3 to 6 months, and you may get to adjust the dose again after that when you've been reassessed to see if that dose is effective for you. And really choosing the right dose is a bit of a balance. It's a bit of a negotiation between you and your healthcare provider. Our focus is going to be on how effective the medication is. So we want you to get up to a dose that we find will be helpful for you so that your pulmonary hypertension is treated and so you can breathe better and resume a normal life. But the other aspect of it is clearly quality of life. We've talked a little bit about side effects, and I'm going to talk a little bit again about those a bit more today. But you don't want to have a longer life if you're so miserable from the side effects that you would rather be alive. And so healthcare provider to find a dose that works for you that doesn't heavily impact your quality of life and lets you enjoy this life you've earned by starting on one of these medications. Efficacy. So, I mean, this is like one of the key topics that people ask me about, okay? So you're asking me to think about starting on one of these serious medications that involve, a hospital stay, a relatively major lifestyle change, especially in the beginning. Why is it that we do that, okay? The goal of all of these medications is to improve both the quantity and the quality of your life, okay? We want to reduce the pressure in your lungs. We want to improve the function in your heart. We want you to walk farther. We want you to breathe easier. We want you to have more energy, okay? So when I describe efficacy to my patients, often what I'll say is this, okay? You don't know beforehand you're going to respond to the medication. Some patients respond extremely well and do extremely well with this medication, only respond a little bit, so much so that they're able to go to the hospital or live their life until a lung transplant becomes available. And so while these aren't direct estimates, it can be helpful for you to have an idea about how many people have what type of response, okay? So I would say about 30% of my patients, the high blood pressure in their lungs returns to normal and their heart function returns to normal. And they feel normal, their breathing feels normal as long as they stay on the medication, okay? These kind of people who have this type of response can live 5 years, 10 years, 15 years, 20 years or more. Okay, I have patients who started on this medication when they were 12 years old and made it into their late 30s before they needed to have a lung transplant. Okay, so this would be the ideal response. This is the type of response that everyone's hoping for. And to be honest with you, your entire healthcare team is cheering with every cell in their body that this is the type of response that you're going to have, okay? So that's about 30% of my patients. About 40% of my patients, the high blood pressure in the lungs comes down a little bit, the heart function improves a little bit. You personally will feel better. You'll be able to do more, be able to resume a more normal life. So tasks that were difficult for you become easier, but you might be left with a bit of persistent shortness of breath on exertion. So you might be still more short of breath than your husband or your friend or your partner, what have you. And so these kind of patients who have this kind of response, so this is the largest portion of my patients, often they're looking at living about 5 to 10 years before they need to start thinking about going ahead with a lung transplant, okay? And the smallest portion of my patients, I'd say about 20% of my patients, the high blood pressure in the lungs comes down a tiny bit, the heart function improves a bit, and the disease, we know the disease is progressive, it gets worse over time. The disease stops progressing, but often they're not well enough that they don't, get as long of a life after starting these medications. And so often people who have this type of response are looking to have a lung transplant about 1 to 2 years after starting those medications, if lung transplant is a possibility for you, okay? It's really difficult that we don't know beforehand, before starting these medications, what type of response you have. I've had people who are very sick, who've had very great responses. I've had people who are moderately sick, who the medication didn't really seem to make a difference, that the disease continued to slowly progress, even if the disease progression was slowed down. Okay, so I hope that's helpful for you for thinking about when you're starting the medications about what possible outcomes you might have. Side effects. So side effects are pretty common with these medications. Over the last 10 years, huge range of response. I'm an honest person. I've been living this, I've been working this area for 10 years. I'm not going to necessarily sugarcoat, but I'm also good. The full range. I've seen people who've had the worst experience and the people who've had the best experience, and I'm going to discuss the full range of those experiences. Most commonly, first, when you're starting on the medication, so in those first couple of months, as we're bumping up the dose to an effective dose. And in fact, most of my patients tell me that when they increase their dose for 2 or 3 days, they feel like crap. And then after that, for the rest of the week, they do okay, until it comes time to bump up their medication as well. So some of my patients, they choose to titrate quickly because they want to have all the side effects and they want to get it over with because they just want to do this, they want to be done, and they want to move on. And some people really struggle with feeling uncomfortable. And so those are patients that want to take things slowly and carefully as they're increasing their medications so that the side effects are manageable and they can continue to function. And this is something you can work very carefully with your healthcare team to decide how you want to go through this. So what are the side effects? Okay. Pain is definitely one of the medications. Some people, like not everyone experiences all medications. Not everyone experiences all of these side effects. People experience one or two. And typically after the titration period is over, are kind of left with one or two bothersome side effects. So they're not debilitating, they're more just bothersome on a day-to-day basis, constantly looking at ways to people side effects after complete. Okay, so pain. Mostly the issues that we see medication to be, your full frontal headache. And typically for the first 12 hours after starting the dose, starting to increase your dose, headache can be a real problem. Okay. Some people have problems with headaches longer term. And what are some of the things that you can do when you have a headache? Okay. So we start pretty simple, on the day you're having a bad headache, if you want to take it a little bit easier, do a little bit less work, do a little bit less activity when the headaches are bothering you, never a bad idea. There are different medications that you can try for headache. So some people use simple things like Tylenol. Other people need to go more complex things. There are medications for migraine headaches that you can use. And if none of these things are working, often we can speak to a specialist in a particular area and see if they have any extra advice outside of the common things for things that you can do with headache. Other types of pain, okay, so you can have some bone pain. So mostly when I'm talking bone pain, some of my patients have had almost like a deep ache in their femur, so in the big bone in their leg. Or more commonly, where I tend to see people have bone pain is in their heels. So their feet hurt after they've been standing for a long time, okay? Again, you can take medications to help you manage this type of pain. But often I find for this, seeing a podiatrist or a physiotherapist and getting orthotics, I find to be more helpful over the longer term for this type of pain. Myalgia, so muscle aches. Often this is fairly limited. Often I see this more commonly in the first 2 to 3 days as the dose is increased. And then again, as you're on a stable dose, those side effects pass away. But again, some people almost describe it as like having a cold or a flu. So you're kind of, your muscles ache, you're just sore all over. It's like a generalized feeling of soreness. Nerve pain is probably one of the least well-tolerated types of pain that I see people have. And so often this is like sciatica. So you get a shooting kind of nerve pain from your back down one or both of your legs, or you can end up with something called peripheral neuropathy, which is something that diabetics can get as well, where you kind of end up with numbness and tingling in your feet. And again, there are some medications that can be used to help with this. And there's also some supplements and some vitamins that can help with this nerve pain as well. And again, part of this, is choosing the right dose of the medication for you. So if you're finding that this pain is overwhelming and it's really impacting your ability to function, looking at how well you're doing with your pulmonary hypertension at the time and how much side effects you're having, adjusting your doses is something that we do pretty regularly with some of my patients. We go up, we go down, and again, staying in good contact with your healthcare provider when you're doing that is great. I see there's some questions. I'm assuming we're going to be waiting till the end to discuss, or should I answer them as I'm going along?
We were just having some audio issues, Lisa, but we hear you better now. So if it comes up again, I might interrupt, but it was just recording that we were having some trouble hearing you, but it seems okay now.
Oh, okay. Next time, just interrupt me earlier if you're having troubles hearing me and we can try to fix it.
Okay.
Okay. So we talked, this is one of the common topics. And for those of you who were on the patient directed version, we talked about, Nicole talked about site pain, and she calls it Hell Week, or when you're putting a new site in. So this is with subcutaneous Remodulin only. This is not with IV Remodulin. This is not with Caripul. So these are not the 2 IV medications. This is that little one that we were talking about in the arm. And you can see we have here a very small child with pulmonary hypertension. A very small child with pulmonary hypertension who has a site in there, okay? So the pain for sub-Q Remodulin is, again, typically just as you're putting in the new site. So typically the pain will start around day 2 or day 3. It'll peak on around day 5, 6, 7, and then it will start to come down. And then again, like Nicole said, you know, once that pain is gone, it's like it's never happened. Some of my patients have a little bit of tenderness at the site, so if they accidentally bruise or bump it, they have pain for, you know, they'll have pain again for a little bit after they've bumped it, but then again, it will tend to settle down. And we kind of take a stepwise approach to this. So we'll start with heat or ice at the site. And sometimes this is something that is the simple things that people miss that can make a real difference. You know, we use ice on other types for other types of swelling or other types of pain. That works really well for subcutaneous Remodulin. Again, it doesn't last forever. So typically, this is something that will work for 10 or 15 minutes or so, and then you'll need to rotate to something else. There's topical creams. So McKesson is the pharmacy that distributes Remodulin. They can send you out a topical cream that's got a bunch of wonderful medications in it. Some of my patients find this extremely helpful. Other people don't find it doesn't help at all. If the topical things aren't helping, sometimes we'll try oral medications. Sometimes you need to take these medications just for those 2 or 3 days when the pain is the worst. And some of them are helpful to take longer term. We do sometimes have to use stronger medications to treat site pain. And so often some of my patients are taking stronger medications for day 3, 4, 5, 6, 7. And then again, they slowly wean off those medications. So there's time in between. And again, I have elected to refer quite a few of my patients who are struggling with pain to a pain specialist to see if they have other suggestions as well. Okay. Other things that people have found helpful, so dry sites, so putting in a site about 24 hours before you're going to use it. The theory behind this is that it will reduce the local inflammation behind there and make it so your site isn't quite so reactive. Another thing that we do is to try to preserve the site. So make sure your site is secure and in place so that way it doesn't accidentally fall out. Often people are willing to tolerate pain if they know it's going to be for a short period of time. But if they have to experience that pain frequently, it makes them less inclined to stay on a medication. Choose where you put your site very carefully. So a lot of my patients find they have less pain in the back of their arms. Some of my patients have found that the stomach is better, but you want to try to avoid a place where you're going to be, you know, buckling up your seatbelt or the waistband of your pants or constantly bumping up against. So choose where you've put your subsite in pretty carefully. And if all else fails, I don't know why if all else fails, you can also consider choosing a different way of getting the medication, okay? So typically I say if you're gonna start Remodulin, you should try to commit for a 3-month, 6-month, 9-month period so that you can see how you're feeling at your best and how you're feeling at your worst. And you kind of almost don't wanna make a decision in the heat of the moment when the pain is really bad, because maybe once you are outside of that period of pain, you know, you're going to be feeling great. You're going to look at how much this medication has done for you. You know, you've gone from being short of breath and not being able to work to being able to participate at work again and go out and walk and do things. And so, you know, if you kind of give it some time, really, really try, and if the medication is not for you, you know, there are other ways of getting the medication, and you can try a different prostacyclin if this one is not for you. Again, not everybody, and I mean this, not every patient that I have has site pain with Remodulin. I have patients who've told me, Lisa, you told me this was going to be terrible. It's really not that bad. It's been 3 to 5 days. And then I've had other patients who have like sobbed on the phone because the pain is so debilitating. And so there can be the huge range. And again, you don't know beforehand which kind of person you're going to be with that pain. But just know that we're around and that we'll try to support you as much as possible through this if you are having pain. Systemic problems are pretty common with these medications, most commonly nausea. So again, this doesn't tend to be a long-term problem. I've had 1 or 2 patients who have had this longer term. Yeah, 1 or 2, I would say. But it is very common when you're first starting on the medication. There are oral medications that you can take. There are specific foods that are a little bit easier to tolerate and digest with the nausea. And if it's a longer term problem, definitely keep bringing it up with your healthcare providers, because there's different ways that we can either adjust the dose of the pulmonary hypertension medications or the medications that we're using to try to control the nausea to help. So diarrhea or loose stools, again, honestly, I think this one is the most common side effect that my patients have longer term, no matter which medication that you're on, that you more frequently need to use the bathroom and more urgently need to use a bathroom. And to be quite frank, for the most part, if this is an ongoing problem for you, typically I suggest that you just take 1 or 2 Imodium every morning. Here in BC, I can get pharmacare coverage for it, so you don't have to pay for it. And you can just take that every single morning and then take some extras as it comes and goes. It tends to be frustrating for some people because they'll go a couple of weeks without this being a problem, and all of a sudden it'll be a surprise, and they'll have to reorganize their whole life and their whole day and worry about when they have to go to the bathroom. But again, if this is a side effect that you're struggling with, definitely contact your healthcare provider, and we can talk about some different ways that we can find for you to manage this longer term. Loss of appetite. This one, again, like the nausea, I find very acute, but this can be something that's quite cyclical. So you really need to get on top of this one. Again, if you remember, we talked about the fact that these medications are weight-based. And so if they're weight-based and you lose weight, the concentration of the medication goes up in your system, you have more side effects, you lose your appetite, you lose weight, and so this terrible rotating circle. So if you find that you're struggling to eat, please let me know. Please let your healthcare provider know. This one, again, tends to be very short-term limited. The longest I've kind of seen it last is about 3 to 6 months after starting on the medication, and then it tends to go away. Eating small, frequent meals can help. It's the time in your life where you're allowed to eat pretty much anything that you want that's not high in salt content, clearly. But, I've seen my patients do things like pour Boost on ice cream because they're struggling to get the calories in. And again, as long as you're not impacting either, like I said, the salt content in your diet or your fluid restriction, usually you can be okay. This one can be pretty hard for people to take because food does give us joy. But again, this is one, again, like I said, that is very self-limiting. It doesn't tend to stick around longer term. Emergencies. So part of being on this medication is, kind of taking on the responsibility for your own health and making sure that you stay safe. So there are, I wonder how to put this best. So for both Remodulin and for Caripul, one of the things that your healthcare providers are going to talk to you about is this concern, what happens if there's a problem with the medication and the medication stops. Okay, so this can happen for a variety of reasons, and I'm going to show you the list, and then I'm going to scroll back because nobody really wants to sit here and look at someone's blood on the floor. But I can assure you that emergencies do happen with these medications. So things happen. Your line can fall out. Your line can get blocked. You can get a hole in your line. I have a patient right now in VGH who's right after I finished this presentation, I'm heading down to the interventional radiology department to sit with her while she gets her new line put in, right? So emergencies do happen. But part of the process of starting on these medications is your healthcare provider is going to go through you. What are the possible things that can go wrong? And then here's what you do in an emergency. And because we all don't necessarily do the best at critical thinking when we're in an emergency, our stress levels are high, we're making silly mistakes, or we just can't think. For both medications, there's a 24-hour emergency line that's available for you to call, okay? So there's somebody on call 24 hours a day. So if something happens and you don't know what to do, you don't remember what you were taught, you just pick up that phone and you call, and the person on the other line is going to be somebody who knows you, who knows pulmonary hypertension, who knows every possible emergency that could happen with these infusions, and they'll know how to fix it. The first thing that they might tell you is to hang up the phone and call 911 so you have help on the way. And then they'll say, call back, or they'll call you back after a couple of minutes, and they'll sit there on the phone with you and they'll talk you through, okay, here's what you're going to do. And if you're the caregiver or support person, or, it's a stranger on the street, anyone can call that number. We'll talk to anybody. It's a resource for absolutely everyone that's here. I've been doing this for 10 years. I've had a variety of emergencies and scenarios and shenanigans that my patients have got into, as you imagine, that once you feel better, you resume a normal life. Things happen. And I can tell you that I haven't had a single patient pass away from one of these emergencies that happen. So even though we really emphasize this in the starting process and the teaching process, the reason why we do so well with this is because we do pay attention to emergencies, and we do provide you with the support so that if an emergency rises, you can manage that. Okay. So I wanted to talk about this a little bit because I think this is probably one of the main concerns that my patients have when starting these medications is, okay, I'm going to start on this medication. I'm going to do my hospital stay. What's going to happen afterwards? Okay, I'm feeling better. I've had my 3-month checkup. I've had my 6-month checkup maybe. My breathing's a lot better. I'm able to walk farther. I know what kind of outcome I'm going to get from having started on this medication. What's that life going to look like? I don't either want to minimize what it's like to have to live on prostacyclin therapy, because clearly I don't have to live on prostacyclin therapy. But I also want to say that I've seen some really inspirational things over the years. I've seen people work, travel, exercise, all kinds of stuff on these medications. And it's not in the first 3 or 6 months when you're starting on the medication and you're adjusting and you're learning. It's later on. I think it's really helpful having Carl and Nicole on that last talk we did, because both of them, have really taken the life that they were given and done lots of wonderful things with that. Okay. So for work, especially for IV bupropion, sometimes I recommend for the first 1 to 2 months after starting on this medication, that you stay at home and that you don't work. Okay. Having pulmonary hypertension, people are living longer and longer. So it's not even the immediate crisis. It's energy conservation for a longer period of time. You're going to start on this medication, yes, but then what's going to be the next thing or, stressor that's in your life? And so if you have this opportunity, you clearly are unwell, and if you have the opportunity to take time off, it's probably a good idea to take 1 or 2 months off when you're starting prostacyclin therapy. If you do want to return to work, Typically, I recommend that you start with reduced working hours. So we're happy to put together return to work plans. And I find sometimes people do better working a 0.8 FTE. So working, instead of 40 hours a week, working 30 hours a week, if it works out. Obviously, not all of us have that opportunity. Some of us have financial reasons why they need to continue to work, et cetera, et cetera. But for those patients who've had a good response to medication, most of them have been able to resume working, okay, in one form or the other. Sometimes you have to do a little bit more sedentary work. Maybe you aren't going to be working in a warehouse, lifting heavy boxes, et cetera, but there's lots of opportunities. I have people return to work as lawyers, as statisticians, as retail workers, all kinds of things, parts employees. I've seen everything. People have managed to return to work and make it work. Travel. So traveling is an interesting one. Again, give it some time, get settled in, have an emergency or two, make a mistake or two, do it while you're here, where your healthcare provider knows you, et cetera, et cetera. At some point you may want to travel. Probably the first 6 months or so may not be that time. Maybe this will turn out to be super easy for you and you just resume traveling. But if, I've had patients on Caripul with children, CPAP and oxygen who have gone to Disney World, so it's harder. Again, I'm not going to sugarcoat that. It's difficult. There's a lot of logistics. You need to be organized and you need to talk to your healthcare provider, but travel is definitely possible. We also recommend that, you let us know where you're going and we can kind of tell you, okay, you're going somewhere where there's not going to be a lot of medical resources for you. They don't know very much about pulmonary hypertension. They don't have this medication in that country. Maybe that's not the best place for you to go. But, if you're traveling to Toronto from BC, or you're going to the United States, or you're going to Europe, or you're going to certain South American countries, right? I can even send a quick email to the director of that clinic and say, hey, my Caripul patient is coming here. I'm not anticipating that they're going to have any problems, but if they are, here's some information about them, and you should call me if they run into problems, and then I can help you talk through that. Showering. So you've got this IV in place. For the first 8 weeks, I recommend that you shower with your dressing on. So you're going to have your dressing that's covering your central line, and then you're going to have another extra dressing on top to protect that dressing, and you're going to have a shower. Okay, so for the first 8 weeks, personal hygiene, maybe it's a little bit annoying to figure out. Maybe you don't shower as much as you would normally do, but eventually it will become routine like everything else with being on this medication, and you'll be able to figure it out. After 8 weeks or after your site's healed, I would talk to your individual healthcare provider in your local clinic about whether you can go without a dressing, because a lot of my patients go without a dressing either permanently or even while they're showering. Swimming. Everyone's favorite peer topic when it comes to pulmonary hypertension infusions. My medical recommendation is that you don't swim. The reality is the vast majority of my patients swim. So the issue with swimming is that it increases your risk of having a bloodstream infection, because there's bacteria in water that, as well as you do with covering up all of your connections with waterproof tape and et cetera, eventually I have seen some people get infections from swimming. You also have to be careful because you need to keep the pump dry. We have had one pump malfunction because the pump got wet. So there's a variety of commercial products that people can use to try to keep their pump dry. I'm sure that the Shoppers Drug Mart nurses on this webinar are probably cringing as they're listening to me say this, because the pumps are like 10 very expensive, $5,000 to $10,000 each, I believe. They can quote me on that. I can clarify that later, but they're quite expensive. So if you do choose to swim, again, discuss with your healthcare provider. Often what I'll do is I'll tell you that I recommend that you don't swim. Here's somebody who is swimming. Here's what I've seen them do. Here's what's good about what they're doing. Here's bad about what they're doing. And often this is something that's sourced peer-to-peer as well. Exercise. So this is regularly a question I get about 3 to 6 months after starting on this medication. It's like, all right, I'm starting to feel a little bit better. I have a little bit less side effects. I've heard that exercise is good in pulmonary hypertension. What can I do? Okay. So you're going to start again, talk to your doctor, talk to your nurse, see what they think. There's times when exercise is really helpful in pulmonary hypertension. It's great. And there's other times when we say, oh, let's give it another month. Your heart's still pretty fragile. Let's let the medication do its job. And once we reach a stable amount, we'll talk about an exercise program for you. Some of the programs across Canada have supervised exercise programs. So basically you'll come into a rehab type place supervised by a physiotherapist or a respiratory therapist, and they will teach you how to exercise. It's not available everywhere. And like in BC, all the patients with pulmonary hypertension come to the Pulmonary Hypertension Clinic. And so it's not available to everybody. There's a really great resource on the PHA US website that kind of talks about pulmonary hypertension and exercise, and I'm happy to share that with you if you're interested. But typically what I say is start slow, and progress slowly. So where are you at? Are you able to walk down the hallway, or are you able to walk to the grocery store and get your groceries and come home? Okay, because that's like, where are you at, and where are we trying to get to? For me, you know, if you're really struggling, if you're having lots of difficulty with your breathing, you know, say you're walking 30 meters, it'll be like, okay, so walk 30 meters twice a day to start. Do that for a week, okay? Then either try walking 40 meters twice a day, or walk 30 meters 3 times a day. Okay, so you're either going to increase the frequency that you're doing your exercise, or you're going to increase the duration, or you're going to increase the intensity, but you're not going to do all 3 of those at the same time. And you really want to pay attention to yourself. If you're feeling dizzy ever, stop exercising, okay? Even for me, if I feel dizzy, I'm going to stop exercising. But for you, it's especially important. Exercising means that you're feeling dizzy means you're outstripping the capacity of your heart while you're exercising, and you just want to reel it back in a little bit, okay? You know, there's lots of really great evidence to suggest that exercise is almost as effective as medications when it comes to improving how you're functioning. So I'm a big fan of exercising, and it's something that I talk to my patients about a lot. And so if you need more information, definitely get in touch. Sex, so it's kind of a big deal. I remember one of my patients early on in about 2013, she pointed to the line and her chest and said, "This is valuable real estate for women, and you're going to ask me to put an IV line right there." I get it, like 100%. I get it. Dating is hard enough. Dating with this addition of something to your body is also interesting. On the other side of things, I've also had a patient tell me, oh my goodness, what is it? Oh, it turns out that people aren't too worried about dating a cyborg. So a combination of machine and person, they were able to successfully manage dating, okay? But talking about the physical act, clearly you want to be safe. So you want to avoid accidentally discontinuing your medication while you're having sex. So I have had somebody 3 weeks after starting on the medication and getting a line put in, have their partner kneel on their line and have the line come out. Okay, so we need to physically be cognizant of where the stuff is, which clearly is an issue in the heat of a moment, to not always be completely aware with what's going on in your physical environment, but that is something to pay attention to. And then the other issue is clearly exertion, right? So there can be better and worse positions for you when it comes to sex. And we actually have a pamphlet in the PH clinic that can be helpful for people if it's needed to be shared. Okay, so I've talked a lot about a lot of things, right? Hospital stays, dosing, side effects, efficacies, outcomes. So why do we do this? Why is it? And I think a lot of this comes back to, those first couple of slides that I showed you. Prior to the 1990s, there was no treatments for pulmonary hypertension. People would get pulmonary hypertension and they would die within 3 to 5 years of receiving a diagnosis, or they would need to go into lung transplant, okay? And I've seen some people in pretty dire straits start on these medications who I still see now, whose kids who were, 8 to 10 at the time, who were asking me if they could learn how to mix up their mother's medication. I've seen those kids graduate from high school. And so it's a lot in the moment when you're taking this on. But over time, like everything else, you do get used to some things. You may not like it. You may have good days. You may have bad days, but you do get used to it. And one of the major things I think about starting on this medication, I started in the clinic around 2012, and John Swiston was talking to one patient, and he said, one of the reasons why we ask you to think about this is, maybe this is just temporary. Maybe you just need to be on this temporarily, and maybe there's something that's coming down the pipes that's going to be better, that's going to be easier in a couple of years, and maybe this won't be the entirety of your future. I mean, I've been doing this for 10 years. We're still waiting for those things to come down the pipe, but it is definitely something to think about as well. But what I did want to show you was some of the lovely people that I've had to work with over the years. Some of you may know Tarja. So I swear Tarja and I sometimes were twins separated at birth. She started in the Pulmonary Hypertension Clinic in 2012. I started in the Pulmonary Hypertension Clinic at 2012. She started on oral therapy originally back then. She decided at that point, even though we recommended that she start on IV therapy, she made the decision to start with pills. And she made it all the way from 2012 to 2017 when she started on Caripul. And this is a picture she sent me because it was a big moment for her. She was frustrated with the pump. It was just like in this bag, over her shoulder, around her waist, constantly in the way. And then she found something called a stash band, which is like an elastic stretchy band that she could put her pump in. And she found it was game-changing for her. And you can see here from this picture, you can't even really tell that she's on IV therapy. And so she was just so excited about, the fact that she could just live a relatively normal life and look like a regular person when she went out. So she was on the IV therapy from 2017. She started having lots of problems with infections, and then she went on back off of the IV onto Selexipag. And she's been on Selexipag from 2020 till now. This is Jessica Bueller. She's also a patient of ours. I met her in 2014. She was very sick in 2014. She had very advanced symptoms. The disease was quite advanced, but she had one of those magical moments that pulmonary hypertension patients sometimes get to experience, and she had vasoactive pulmonary hypertension, which means when they gave her a specific substance during her heart catheterization, she had a very treatable form of pulmonary hypertension. And so she was actually able to avoid IV therapy from 2014 until about March of 2022. This is her starting on Caripul in March of 2022. She felt pretty crappy afterwards, and it took her a long time. But I do want to show you that eventually she feels better. This is her out. Carl had I think most of you guys know Carl. I met Carl, mine says October of 2020 here. But Carl, I met in the hospital. He was very sick. And like he said in his presentation, I walked in and I told him that this is what we were doing. I mean, we do give people a choice, but Carl was staring down a very long barrel of a gun, and he made the right choice, and he's been doing excellent with his IV therapy. His line has fallen out. Yes, it has. And his pulmonary hypertension is extremely well controlled. And he is also, like Tarja, considering a transition to oral therapy because he's having problems with headaches on the IV therapy. It's not an easy decision to make by any means, but it is one that sometimes people consider. This is my friend Wendy. Wendy Cameron is a lovely lady. She's a type of pulmonary hypertension called chronic thromboembolic pulmonary hypertension. She lives out in Ashcroft, BC. She's 70 years old, and she loves her animals. And she started out on sub-Q Remodulin, and she had some problems with site pain. And so after a couple of years, switched to IV Remodulin. And here's her with her goats. She looks very happy out there with her transition. And she sent me this picture the other day, and she said, I don't know, I think it's probably not the best picture of me. She's struggling with her health at this point. But I personally think that she looks beautiful. This is my friend Caitlin. Caitlin has pulmonary hypertension, and I met her in December of 2018. She also presented pretty near late in the disease, and she went immediately on to IV therapy, and she's been on IV therapy since then, and her pulmonary hypertension has been relatively normal. So she's 5 years out from starting on Caripul, and she's doing great. And as you can see, she is swimming. And this is Melissa Erickson. Melissa Erickson was more recently diagnosed. She lives out in the interior. Here she is with her husband and her daughter. She just started in September of 2022, so she's about 6 months in, and her pulmonary hypertension is relatively well controlled. Her pulmonary hypertension is normal, and her heart function is normal, and she's feeling pretty great. She's stuck with sub-Q Remodulin because she has congenital heart disease, so she has an ongoing issue with site pain, but she's actually done pretty figuring out how to manage it. She takes her rest days needs to, homeschool, and she's doing quite well. Where are we for time? So I have two really quick things that I want to cover, and if Kim thinks it's okay, I can keep talking and then we can open it to questions, or if people want to get going, we can do questions now.
I think you're okay to cover the few things you want to chat about, and then we'll wrap up.
Excellent, perfect. So both of these slides will be really quick. But the future of prostacyclin therapy. So, I mean, again, I've been doing this since 2012, and you know, the medications that we have now may not be the medications that we always use for pulmonary hypertension. And there's always talk of new things coming down the pipe. So, you know, there's painless subcutaneous Remodulin. So they're looking for a way to administer sub-Q Remodulin so that people don't have site pain, and people are very much looking forward to that. There's an implanted type of Remodulin where instead of the pump and the line being outside of your body, it's on the inside of your body. So that is something that they're continuing to look at. And then there's inhaled medications. So medications, instead of an infusion attached to you, you getting it all of the time, you know, through a pump, maybe just taking a portable inhaler with you places so that you could get the medication that you need. Okay. So even though these are the medications that we have now, these may not be the medications that we have, the options that we have for all time. I mean, there's a lot of drug development, drug research, especially as our knowledge of genetics advances, our knowledges of treatments for pulmonary hypertension are out there. And there is always remains the hope that somebody will be able to find a cure for pulmonary hypertension, or what is more likely, multiple cures for pulmonary hypertension. And then the last thing, and what I wanted to address is some of my patients decide that pulmonary hypertension therapy isn't for them. So maybe it's now. So maybe now is not a good time to start on prostacyclin therapy, or maybe it's ever. Okay. And there's not, you know, this isn't a choice that's frequently made. I think that more commonly people choose to go on prostacyclin therapy versus not going on prostacyclin therapy. But, you know, if this is a decision, you know, if it's just the thought of going on prostacyclin therapy is like so overwhelming to you that you feel it will impact your quality of life. You know, I think that for some people, I 100% understand that. I think that if you've been given all of the information, if you've had the opportunity to talk to other patients who have pulmonary hypertension, if you've seen somebody go through the process of starting on one of these medications and you decide that it's not for you, you know, I don't think, like, I don't think that people should necessarily hold that against you or think that you're making the wrong decision. Sometimes it is the right decision for somebody to not start on these medications. And if that's the case, you know, it doesn't mean that you stop being a patient of the Pulmonary Hypertension Clinic, or that you don't get to continue to enjoy the support and the resources of being attached to the Pulmonary Hypertension Clinic. And it really shouldn't impact your relationship with your doctor or your nurse, okay? You know, they're going to want to know that you understand the risks and the benefits of this choice. But I think almost universally across Canada, you know, if you decide to not go on prostacyclin therapy, you know, I don't think people would fault you for that, okay? And it's not like, you know, unless you're already in the hospital, and if you're having to make this decision in the hospital when you're extremely sick, it's obviously a lot harder. But you know, if it's, you know, lots of times when we talk to patients about prostacyclin therapy, you know, you have time, you've got some time, you've got a month, you've got 2 months, you've got 3 months to kind of think about, you know, is this right for me? And, you know, make sure that you talk to your doctor or nurse and be like, okay, so if I choose not to do this, you know, what's it going to look like for me? Am I going to suffer? Am I going to, you know, what's that going to look? What's that trajectory going to look like for me? And sometimes they can't give you specific answers. You know, lots of times people kind of develop slowly progressive shortness of breath. Okay, and then they start retaining fluid, and then, you know, sometimes it starts impacting some of your other organs in your body, and it can look different for other people. And so, you know, if this decision is really weighing on you, you know, sometimes hearing about what happens if you decide this isn't for you can also be helpful for you to make a choice. There's a lot of support out there, either way you go. You know, there's palliative care doctors you can speak to. You can speak to your nurse or your physician in your clinic. You know, there's social workers, there's psychological support, there's other stuff out there. Depending on which community you're in really does impact, you know, what type of resources are available to you. Your family doctor, a lot of people can kind of talk to you about what happens after this.